So I think it's
Okay, if it is time, I think we can start. Dr. Uma
yes.
will join in.
Sure. I good evening to all. I call the meeting to order. Okay. Oops. Sorry. It's a I would like I want to play, first thank Dr. Ravishankar and Kavita ma'am to be present during this meeting. So a hearty welcome to both of you, and thank you for all for joining this meeting, and to listen to Dr. Talk about his experience in the kind of work that he is doing. So thank you so much, Doctor. I request, probably I can call for the invocation song before I start the meeting. So can Gokul is there?
Kiran, you can render.
Oh, Kiran, please render.
You're the all-rounder today. In small sloka.
I'll try my best. My voice is not
no complaints.
good. Okay. This is the one for all, to the whole world. Sarve bhavantu sukhinaha, sarve santu niramaya, sarve bhadrani pashyantu, ma kaschit dukkha bhag bhavet. Om Shanti Shanti Shanti.
Good sloka.
Thank you, Kiran. Thank you so much. I request Justin to announce birthdays and anniversaries for the. Today is the 2nd of August, 1st of August. So it's a new beginning, new month.
Yes.
So please, Justin, if you could tell us who is celebrating.
Today is Dr. Elizabeth's birthday, the upcoming DGE. Tomorrow is Gnaneshwari's wedding anniversary. And 9th is Nagaraj's wedding anniversary.
Wow. So we have celebrations in place.
Oh.
Nagaraj? I guess he's...
Yes, Tarun. Yes, Tarun. Good evening.
Good evening. Wishing you a very happy wedding anniversary.
Thank you all. This is my 15th wedding anniversary.
Wow.
And I don't know how 15 years went off for married life successfully.
That's nice.
Thank you for all your support for everything in the Rotary journey.
Yes.
Nagaraj, you already have 2 kids to remind you of those 15 years. So enjoy it.
Yes. Justin, can we start with a small introduction? Not doctor's introduction is not much required, but everybody knows him. But then, can you please give a small introduction to Doctor?
Sure. Yeah. Dr. K.B. Ravishankar is the medical director of Ushakiran Hospital. He is the managing trustee. He is the technical cadre advisor for Rotary Foundation, particularly the TRF. He has done his share in humanitarian grants. He is the advisor for major grant projects. He is a life member of RAGS for BP, that is Rotary Action Group for Blindness Prevention. He's active there. He is active in the International Rotary Group of Health Professionals. He was honored by many other organizations. He has volunteered for eye surgeries all over the world, in India and overseas, like India, Nepal, Gambia, Guinea, Honduras. He was invited for the Lisbon Rotary to lead the breakout session during the TRF event. In all, he has done over 50,000 surgeries. 50% of those he has done at subsidized costs. He has provided 12,000 glasses and performed 1,000 surgeries free of cost. He has screened over 400,000 children. And talking about Dr. Uma, she has also equally participated in whatever Dr. Ravishankar has done. She has served for 30 years in this field. She is specialized in cornea and external eye diseases. She has lectured throughout the country, outside the state and outside the country also in her field. She has volunteered in Mysore since 2000 and has done surgeries for over 50,000 people. The same way Dr. Ravishankar has done, she has also done. She has also volunteered outside the country in performing the surgeries. She is the consultant ophthalmologist for Ushakiran Hospital and the associate medical director and the trustee in Ushakiran Hospital. She is an honored invitee for the American Academy of Ophthalmologists. She was honored with the title Eye Help Hero for her services in ophthalmology. We are privileged to have both of you talking to us. Thank you, Doctor and Dr. Uma. Over to you, Arun.
Thank you so much, Justin. It's a proud moment for all of us to listen to Doctor. So, Doctor, the floor is all yours. Thank you so much for being here.
Dr. Uma has just come. She'll just join me in a minute. I'll start the.
Sure.
So this Ghana is in the West Africa. It's almost equivalent to one of our states here, like Karnataka, with a population. And here in the whole of Africa, including Ghana, the proportion for doctor versus the population is very drastically skewed. In India, come. Dr. Uma is joining here.
Good evening, Doctor.
It's very skewed. Whole of India has a population of about 1.4 billion. And that whole of African continent has a population about 1.2 billion.
Oh boy.
Okay. India has a eye surgeon population. Eye surgeon number is over 25,000. It makes it something like 1 in 50,000. For every 50,000 to 60,000 people, there is one eye surgeon in India. And to compare it with even more developed nation like United States, they have an eye surgeon for every 20,000. It is too much on that side. So every 50, 60,000 is very comfortable here. Like here, though India has its set of problems, that disproportionately more number of people in cities and less in villages. All those issues are there. In Ghana and in overall Africa, there is one ophthalmologist for 1 million people. So it's drastically skewed on a negative side. So you can imagine Mysore and surrounding areas, talukas put together, it may be about 2 million people. For 2 million people, we have about 150 eye surgeons here. Whereas the part of the Ghana that we were serving is called Northern region, where the capital of that is Tamale, has a population similar, 2 million, as one eye surgeon. So you can imagine how bad the situation will be and how under what kind of pressures. In addition, there are issues of poverty. There is an issue of other poorly developed medical infrastructure. There are issues of other paramedical personnel and other things also less developed. These are very many challenges are there. And I would like Dr. Uma to run through this PowerPoint presentation. In between, I will also chip in a little bit. And also while we show the videos in the end. And Dr. Uma, kindly start your presentation. This was for the for between July 6th to 16th. I'll request somebody there who is handling the slide to when next slide, I'll request for next slide. Kindly move the slides. Next one, next slide, sir.
Good evening, everybody. Our main mission in Ghana was to at least operate 20 children and adults about 70 or 80. And if there is a local eye surgeon, to transfer some skills and to give some training to the paramedical staff who already were partly trained, but to give them some more insight into cataract and simple surgeries like pediatric surgeries.
Next one, sir.
We operated between 6th and 15 July in Tamale, and the infrastructure was reasonably good. And kept us very comfortable so that we could assist. We got good assistance for the surgeries, and we had taken some supplies, more than enough supplies. So there was no hitches during the performing of the cataract surgeries or any of the other surgeries.
Next one. You can move to the next one.
Sir. So this is the slide showing Accra, and we had gone to a place called Tamale, which was close to the Accra, which is a developed place, whereas Tamale is a moderate township.
Next one.
Again, showing the view of Accra and the northern region of Ghana. You can see these dwellings, modest, showing the poverty levels of this town. But you can see happy children trying to sell some smoked fish and sometimes even rice water along the road to make their living. They are looking happy. The poverty is not shown in their face, happy, smiling faces.
Next one.
Dr. Judith Simon was our host, and she manages the eye center in Tamale for many years, and she has worked in America, and she decided to settle in this modest town so that she really loved the feedback of the people whom she was serving, and she decided to settle down there. She's a very able surgeon and an excellent host.
Next one.
This is a slide showing the preoperative examination of the cataract patient with the slit lamp. And these patients were willingly, happily waiting for somebody to come and operate their cataract. Next slide, please. This slide shows a small corneal tear. That is, a cornea is the black portion of the eye. And there's a small tear here, which is about 2 or 3 millimeters, with a pus collection in the front of the eye, and that is being sutured. And we had put 10-0 nylon, that is like fine hair, like sutures, a couple of sutures, and given antibiotics in the post-operative period and were able to bring it to a decent correction. This slide is showing the paramedics. This left side is actually partly a manager and administrator, and right eye is one of the assistants who ably assisted from morning till almost close to 5 o'clock in the evening.
Next one.
These are the patients who are eagerly brought in a van, and they are waiting with their files to be seen in the pre-operative area, and then they will be posted for the surgery.
Next one.
Again, the patients waiting in the outpatient for pre-operative examination. There is a boy who is having a squint. Here is a slide showing bilateral, both eyes cataract, birth cataract. We do not know the cause. Some antenatal means in the pregnancy, the first 5 months, certain viral illness or some unwanted medications taken by the mother or consanguinity in the parental group, which could produce this cataract. Removal of the cataract will produce a reasonably moderate future for the child, though the visual recovery cannot be compared to adult cataract. Next slide.
Just I will touch upon adult. This is also pediatric cataract, both eyes. This children's cataracts, though the name is the same, the way it is handled and the way it has to be managed in the long term are very different. In the adult cataract, you do the surgery, and if you take care for first one month, more or less, they have reached the shore. But in pediatric cataract, one is the surgically, eye, small eye, children's eye is not exactly just the miniature of the adult's eye. There are very many technical challenges, and also, it's a growing phase. So there are a lot of adjustments to be made for that. And also, after the cataract surgery, there is a thin layer within the lens which we leave behind, on which the lens is placed. That tends to become opaque very soon in children. So during the surgery itself, we need to make sure that that optical zone or the pupillary area is kept clean by opening that central axis, that membrane, after placing the IOL, so that enough light goes into the eye. And also, these children require periodic examination because the powers can change and several other issues these children may be having that needs to be followed up. Next one, sir.
Another slide showing a bilateral cataract. But if you compare bilateral with unilateral cataract, unilateral means only one eye cataract, the results of the bilateral cataract surpass the unilateral cataract. So cataract in only one eye does not mean a very great visual prognosis. But timely intervention and opening up the visual axis and the post-operative periods, the parental guidance of the child to the visual needs, like showing certain colored objects and certain letters, and helping in the post-operative period is equally and important in the crucial in the post-operative period for the next 1 year at least.
Next one, sir.
In midst of all these cataracts, we also saw, unfortunately, a child which right eye has been lost, microphthalmos means a small eye, and sclerocornea, and the left eye showing the opposite, that is a buphthalmos or congenital glaucoma. So this child is having a very poor prognosis, and intervention we did not do, and we've asked Dr. Judith to follow up this case for further, some kind of any surgical intervention and medical interventions in the future. But the prognosis is quite grim in this case.
Next one, sir.
Here is a slide showing the surgical cataract surgery being done with the microscope, and the anesthetist is also around, you can see, and the assistants are sitting next to the surgeon and ably assisting.
Next one.
This is a gross squint, external squint. In the left picture, you can see the eye is turned outward. Quite a very gross squint. Even a normal, a common person, a man can identify this, that it is a squint. and it has been ably and wonderfully corrected. And the post-operative beautiful result being seen the very next day. You can see the straight eyes.
The reason why one needs to do the cataract, the squint operation is very important message is, it is not about cosmetic correction. Cosmetic correction is a byproduct. What most important thing is to give a vision in which the child is able to see simultaneously in both eyes. This is very, very important. This gives the child a 3D perception or a depth perception, which is very, very important in so many professions. Like it could be a pilot, could be a surgeon, could be a driver. In very many professions, you become ineligible if one is carrying the squint. And younger it is operated upon, the better it is for the child's future. It's a cosmetic thing is a byproduct that we get, which everybody is happy, but that's not the primary reason for which the squint has to be operated upon. Next one, sir. This is a droopy lid here in the left eye. The droopy lid has been corrected. The droopy lid, if it is gross, like here, can cover the pupil or the hole in which the light goes inside the eye. So that can come in the way of vision development. That's why this needs to be operated as early as possible. If it is very minor, it can be postponed. Next ones. Explain.
Again, post-operative squint corrected case which had an inward squint or esotropia, which has been corrected, and you can see it is the next day.
We don't have the pre-operative picture here.
Pre-operative picture is not there,
but it's been well corrected. Next ones.
This is a recovery of the post-operative in the post-operative period of the child. Of course, moderate facilities only are available for the recovery and not too many wards, but still somehow the post-operative patients are being managed.
Next one.
Another post-operative child being taken care by the parent and assistants around.
Next one.
Just the operated happy patients in the post lunch session.
Next one.
Here there are also translators in the post-operative patients who will in the next day to translate what are the post-operative instructions which has to be told in great detail, maybe and repeated many times, so that they are accurately followed. So not only post-operative drops, but no head bath, and taking care not to lift weights or rub the operated eye, and using protective shield and glasses during the post-operative period and follow-up of these patients, which is equally crucial.
Next one.
You can see the happy patients in the next day waiting for the post-operative checkup.
Next one, sir.
The detailed post-operative examination being done with a slit lamp, ensuring that the surgery has been done well and there are no issues.
Next ones.
This is one Dr. Bas Giva, who is a very senior eye surgeon from Nigeria. She had come to visit this center from our invitation, actually, to see whether some similar Rotary kind of facilities in her Rotary Eye Center could be created, and how to go about making a good eye center. So she was trying to pick up some points from the Tamale Center, and yes.
We had a lot of exchange. She is a trustee of a Rotary Eye Hospital in Lagos. She was, inviting us to come over there, but because she was not clear about how to go about it, so we were interacting for quite some time. As this visit came up, so then she asked whether she could join in as an observer. So she was as an observer, and she is hoping someday she will create enough infrastructure so that we can join in and do some work together in near future. This is myself with anesthetist and Dr. Judith and Dr. Baskiva in the recovery area. Next one. This is a wonderful part of the Rotary journey of the end of the mission. And there was a very good fellowship meeting arranged by a group of Rotary clubs of Ghana. There are several Rotary clubs which took the initiative. A couple of clubs to name Rotary Club of Accra Industrial, and Rotary Club of Accra Metropolis International. These there are a few more clubs as well. These two clubs took the initiative. They, in fact, Tamale is located 600 kilometers from Ghana, from Accra, the capital, where we land first. So it's a 1 hour 15 minutes flight there. So logistically, it's not so convenient to straight carry on the journey. So we break the journey both ways of 1 day there. So these two Rotary clubs took care of the hospitality and showed us around, and we indeed happened to visit other club as well. Next one, please. And some businessmen of Indian origin hosted us very nicely. And this is a visit to Rotary Club of Accra. This is a 65-year-old club. And the gentleman sitting there, second of from the right, next to me, is past RA Director Sam. So indeed, I had the privilege of meeting him in 2013 Lisbon International Convention, where I was a speaker in one of the TRF breakout sessions, and he was actually chairing the session. He was very happy to meet after a long time. We never expected. Next one. This is some of the Indian Rotarians. The one on the left-hand side is President of Rotary Metropolis International, Mr. Padmanabhan Menon, and with our past RA Director, Sam. And on the right-hand side is Rotarian Kailash Chaurasia. All excellent, good Samaritans wanting to do some meaningful projects in future too. Next one, sir. Okay, kindly play those short videos are there. Kindly play them. After that, we can take a few questions.
It's a microphthalma. So there is this very small volume of the eye which is very difficult to work with.
No, very small eye, and the anterior segment,
We do the beer can.
narrow anterior segment, and rexus will be done, and removal of the capsule, and then removal of the milky cataract, and but a bit challenging case because of the size of the eye.
Next one, sir. This children's cataract here, what Dr. Uma was trying to explain in simple words. This is the same case. You know, unlike adults, the children's cataract will be like this. It will be like a very soft and like cottony type. Can be most of the time vacuumed out of the eye. And the back side of that lens is retained to fix the intraocular lens. And then back side of that layer, the central 2 or 3 millimeters is opened up using a cutter to give a clear optical zone. Next one.
There is a child
Anyway, commentary is there.
who is about 68 days old, has lost one eye unfortunately by sclerocornea and microphthalmia. The other eye, there is a suspicion of congenital glaucoma. Pachymetry showed a pressure of around 33 millimeters. She needs more detailed examination.
Next one, sir.
This is a child with bilateral total congenital cataract.
He's 6 months old.
He's about 6 months old. He's going to go in for the surgery. This is the video of the recession of the medial rectus in progress.
Where we are holding the muscle, we are altering the length by
Shortening the muscle. So in squint, actually, it is an imbalance of the eye muscle strength. Some muscle is working more, some muscle is working less. So we balance it out by strengthening a weak muscle and weakening a strong muscle. So that's how it is here. We are strengthening a muscle by shortening it, just like a rubber band. When it is twisted over, it becomes stronger. It is exactly like that. We shorten the length of the muscle which is working. By that, that muscle becomes stronger.
In your left hand. No. In your left hand. Yeah. Just hold it. Only the tip. Only the tip. Yeah. Just towards you.
We get a calculated amount of the muscle,
Exactly now. About
and we
5
stitch
millimeters.
the remaining muscle onto the where it had originated.
Why you are putting this bulldog clamp is muscle get twisted sometimes. You don't know which is upper and which is lower. I don't think this is the upper one. Not this is the upper one.
The resected muscle is being sutured to the insertion point.
Okay, you can conclude it. All in all, we had the pleasure of operating about 17 children's operation. Out of 13 children, some children had 2 eyes operated, and 57 adult operations in that short span of time. It's not a very big number, but for those individuals, for about 75 families, I think it makes a mountain of difference, especially for children. They say in pediatric ophthalmic work, whatever we do is actually, in terms of financial terms, people's on social terms, they say this is the highest return on investment. This, be it time, be it skill, be it money spent on these children, it goes a long way, because these children are going to live 70, 80, or even 90 years. The youngest child we operated is about 3.5 months, and the eldest child possibly was about 17 or 16 years of age. So we have been able to together. I'm so delighted to work with members of the Rotary Abilities. This is the third or fourth time that you are supporting our activities. 2 times to Africa itself, to Ghana, and we are humbled by your support, that you have come forward each time when we have made a request. You have come forward and supported this noble work, which we love doing it. We feel that, by our act of giving our 2 weeks of time, this much of small difference has been made possible. There are n number of children there. There are a large number of adults there who need the help. Just that there is limitations to what we can do. We can do such a thing once or twice a year, with support of all good Samaritans and well-wishers and supporters like you. We heartily thank you, and we are humbled by your support and good wishes that you send us each time. Thank you indeed. And I invite any questions from you all.
Sure, sir,
Sir,
should I stop the
yes.
recording?
Yeah, you can.
Thank you so much, sir, for the wonderful presentation that you give. I must, it's a noble thing that you've been doing, for which we could, help a little bit. That's about it. But it's all in your hands. You've done such a wonderful job, and like you said, probably 75 people in this world are seeing how beautiful the life is, and all thanks to you, sir. Ma'am, thank you so much. And um, any questions or anything that anybody would like to share?
Sir, I have got a question.
Please, sir.
Nowadays, these children whom, since 2019,